We will speak about the voiding. The lecture will be about the voiding physiology. The micturition reflex. It is a visceral reflex integrated in the spinal cord and follows by the higher center. So the component of the micturition reflex, we have alpha receptor. That stretch receptor is stretch receptors situated in the smooth muscle in the wall of the bladder. They are stimulated by stretch when the urine volume reaches 400 ml. However, the first air to void is filled at the volume of 150 ml. At lowest volume, the receptors are not stimulated because the pressure inside the urinary bladder, intravesical pressure, is maintained constant by relaxation or by elasticity of the wall of the bladder. The relaxation increases the diameter and therefore decreases the intravesical pressures according to the Laplace law that the pressures alpha per 1 per radius, sorry. After this is afferent, the sensory neuron in the parasympathetic nerve, pelvic nerve, and we have the last center is found at the sacral segment, that is 2S3S4, and the efferent at the motor neuron in the parasympathetic nerve, pelvic nerve. And then we have effectors, smooth muscle in the wall of the bladder, the detrusor muscle, which contract, so a smooth muscle of the internal sphincter which relax. Remember that also sympathetic supply the detrusor muscle and internal sphincter, so it does not participate into the micturition reflex. Sympathetic supply the detrusor muscle and internal sphincters and does not participate in the micturition reflex. Relaxation of the muscle of the pelvic floor facilitate micturition. The reflex of micturition can be initiated even before complete filling of the bladder by contraction of the abdominal muscle voluntary to rise intra-abdominal pressure. Effect of the higher centers. Descending tract from the brain may facilitate or inhibit micturition. Facilitatory areas are found in the bones and posterior hypothalamus, whereas inhibitory area is found in the midbrain. So we have facilitatory area, this is found in the bones and the posterior hypothalamus, and the inhibitory is found in the midbrain. Voluntary order from the cerebral cortex acting on the external sphincter, skeletal muscle guarding the bladder, allow or inhibit micturition. So the voluntary order from the cerebral cortex acting on the external sphincter, this is skeletal muscle guarding the bladder, is allow or inhibit micturition. In suitable condition, the subject relaxes external sphincter to allow micturition, or is unsuitable condition, he contracted to inhibit micturition. The voluntary order from the high centers leave the sacral segment to reach the external sphincter through the pudendal nerve, S2, S3, S4, and this is the micturition reflex as you see here. This is the innervation from parasympathetic by pelvic nerve, S2, S3, S4 to the bladder wall, and the somatic by pudendal nerve, S2, S3, S4. And we have also the hypogastric, which comes from T11, T12, L1, L2, hypogastric innervation, a sympathetic, And we mentioned that the sympathetic, as you see here, so we mentioned that the sympathetic supply through the muscle and the internal sphincter, but it does not participate in micturition reflex. This is a very important point. Abnormalities of micturition. We have automatic bladder. When the bladder full, empty involuntary, no voluntary control. Occur due to spinal cord damage above S2. Okay, resulting in interruption of the descending tract from the brain. This causes loss of the voluntary control. The micturition reflex is intact because all components are present. Therefore, bladder filling is followed immediately, automatically by reflex emptying. Patient can be trained to induce micturition before the automatic emptying by scratching the inner aspect of the site. In this patient, the afferent impulse irradiates in the whole sacral segment, causing micturition through the mass reflex. Atonic bladder. When the full bladder does not contract, that's known atonic. This occurs due to damage to the parasympathetic nerve or sacral segment, and this is most common in diabetic patients. The micturition reflex is lost, therefore filling is not followed by emptying, no contraction in the bladder wall. In this form of urine retention, the higher pressure within the bladder may force the droplets of the urine to puff out. This condition is known as overflow incontinence. Enuresis or bedwetting. Most children remain dry at night by the age of 3 to 5 years. However, unintentional discharge from the urine during sleep may occur in children who cannot keep the external sphincter closed during sleep, but the micturition reflex is intact. The cause of this may be unknown. This is primary enuresis. May be associated with problems like diabetes mellitus, diabetes insipidus, epilepsy, urinary tract infection, secondary enuresis. Emotional stress was reported in some cases. Most affected children retain the ability to control the sphincter at the older age. So we'll speak about the bladder function, filling and emptying. Filling is known as storage and emptying is known as voiding. The phases of bladder function are filling and emptying. Normal filling requires absence of involuntary bladder contraction and accommodation. So normal filling requires absence of involuntary bladder contraction and accommodation. Accommodation refers to physiological properties of the bladder that permit filling. So accommodation refers to the physiological properties of the bladder that permit filling. These properties include compliance, that's the volume per pressures of the bladder. So compliance bladder permit low pressure filling. This is a compliant bladder. Compliant bladder is permit low pressure filling. Inflammation or scarring of the bladder can reduce the compliance. Sympathetic nerve system stimulation, it will lead to reduced detrusor tone. But the parasympathetic nerve systems is also reduced, inhibition is also reduced the detrusor tone. So stimulation to sympathetic reduce the detrusor tone. Inhibition to parasympathetic, it lead to reduce detrusor tone. Inflammation and scarring, For scanning, reduce compliance. This is the innervation of the bladder, as you see. That we have T11, T12, L1, L2. This is the sympathetic by hypogastric nerve. And then we have pelvic nerve, which is actually come from S2, S3, S4. This is a pelvic nerve. And then we have the nerve, which carries somatic, the external sphincter S2, S3, S4, pelvic or sacral. Okay, this is the internal sphincter, and this is the external sphincter. The internal sphincter is supplied by hypogastric nerve through the alpha receptor. External supplied by somatic, mainly pudendal nerve. And also we have the center in the bones and into the hypothalamus. So the micturition center is found in the bones. Again, cerebral cortex in the hypothalamus, posterior hypothalamus. The pontine micturiation centers, okay, and BAG. This is the innervation of the urinary bladder. Closed bladder outlet. This is achieved by SNS, SNS stimulation, that's the sympathetic nerve stimulation, increase involuntary sphincter tone. On-off nucleus stimulation, this leads to increased voluntary sphincter tone. Normal emptying requires absence of obstruction, open bladder outlet, relaxation of the pelvic muscle, smooth and striated sphincter. Is a first event in micturition and occur by sympathetic nerve stimulation, sympathetic nerve system inhibition. This decrease involuntary sphincter. On-off nucleus inhibition, this will lead to decreased voluntary sphincter tone. Coordinator detrusor contraction of adequate magnitude and duration. The parasympathetic nervous system inhibition stimulation increase detrusor tone, and sympathetic nervous system inhibition decrease detrusor inhibition. Here, this is a innervation of the bladder, and as you see here, this is a pelvic nerve parasympathetic, hypogastric sympathetic. The parasympathetic stimulate the muscarinic receptor, and the sympathetic stimulate the B3 receptors. So the parasympathetic will lead to stimulation and reduce the tone. Sympathetic stimulation, it will lead to reduce the tone too. So parasympathetic inhibition will lead to parasympathetic inhibition, it will lead to reduce the tone, and sympathetic inhibition, it will lead to sympathetic stimulation, it will lead to inhibition of the tone. And as you see here, this is a hypogastric also on internal sphincter through alpha-1 receptor, and this is within the nerve through somatic innervation. Again, pontine micturating center in the bones, hypogastric nerve from T11, T12, L1, L2, and pelvic nerve S2, S3, S4, carry parasympathetic to muscarinic receptor, and then we have the hypogastric to the B3 receptor, and the somatic to the external. Determine of urine flow. Urine flow is determined by intruder function and outlet resistance. Intruder function is determined by bladder muscle function and function of the nerve that innervates the bladder. Outlet resistance is determined by functional factors of the voluntary or involuntary urethral sphincter. Mechanical factors: extrinsic compression of the urethra, like BPH, and intrinsic obstruction of the urethra, like stricture. Neural control of voiding. We have guarding reflex. The guarding is mainly by external urethral sphincter, so the reflex promote bladder filling by inhibiting the parasympathetic nerve system and activating the sympathetic nerve system. So activation to the sympathetic through the alpha receptor, it will lead to guarding or promote guarding reflex, and inhibition of the parasympathetic, that means inhibition of the contraction to the bladder muscle. Also activating of on nucleus that's innervate through the hypogastric plexus. All this, it will lead to bladder relaxation and sphincter contraction. This is known as guarding reflex. Okay, so it's the same as the hypogastric from the onus nucleus of spinal cord of T11, T12, L1, L2. It will lead to, as you see, activating, it will lead to guard reflex. And activating of sympathetic, also sympathetic through the hypogastric and on of nucleus through the pelvic nerve or sacral nerve, it will lead to inhibition of urination. The same, all this act on the pudendal nerve, inhibition of somatic, and inhibition of sympathetic, activation of one of nucleus and activation of sympathetic, plus inhibition of parasympathetic nerve, lead to guarding reflex. So inhibition of the parasympathetic, that the pelvic nerve here, and activation of on of nucleus and hypogastric sympathetic nerve, all this, it will lead to guarding reflex. When the bladder volume reach the critical level, bladder is full, sensory nerve detect the truth of distension and sign as the spinal cord to suppress the guarding reflex, activate the voiding reflex. The voiding reflex. This reflex promotes the bladder emptying by activating the parasympathetic nerve system and inhibiting the sympathetic and inhibiting the ons nucleus, which collectively lead to bladder contraction, sphincter relaxation, coordinated voiding. And then the micturition will occur. So inhibition of sympathetic and inhibition of on nucleus and induce of contraction of the bladder by parasympathetic nerve system. So this is the main point for micturition. Okay. So stimulation of the bladder by parasympathetic and inhibition of sympathetic. This subsequently lead to inhibition of the internal sphincter contraction, so the urine will pass out through the urethra. So stimulation of parasympathetic and inhibition of sympathetic will lead to emptying of the bladder or voiding reflex. The voiding reflex is usually under stretch voluntary control by central nervous system, which inhibits the reflex until voiding is desired. If the CNS cannot inhibit voiding reflex, when involuntary or autonomic voiding occur, when the bladder becomes full, condition called reflex voiding or automatic bladder, as I mentioned previously. Infants have not developed the CNS control over voiding reflex. Therefore, they have reflex voiding when the bladder is full. Both training help reach voluntary control over the voiding reflex. Patients with certain brain abnormalities, such as stroke, might lose the ability to voluntarily suppress the voiding reflex. Voluntary control over voiding is initiated in various areas of the suprapontine CNS, including the cerebral cortex. The neural pathway for voiding passes through the Parkinson's nucleus in the bones and into the spinal cord. The pathway then continues from the spinal cord to the bladder and also to the voluntary sphincters and involuntary sphincter. Stimulation of Barton's nucleus will activate voiding reflex and promote urination, where suppression of the Barton nucleus will inhibit voiding reflex and promote bladder filling. When the suprapontine CNS loses ability to inhibit Barton nucleus, such as certain type of stroke, the voiding reflex cannot be inhibited. So reflex voiding occurs and the patient typically present with air incontinence. We come to some terminology. Urinary continence. The ability to store urine without leakage. Continence depends mainly on smooth urinary sphincter function. Urinary incontinence, involuntary leak of urine. Detrusor overactivity. Urodynamic observation characterized by involuntary contraction of the detrusor during the filling phase. This can be spontaneous or provoked. So this is the detrusor activity, urodynamic observation characterized by involuntary contraction of the detrusor during filling phase. It can be spontaneous or provoked. Dysfunctional voiding. That's intermittent or fluctuating urine flow caused by involuntary contraction of urethral sphincter or levator muscle during voiding in people without neurological condition. So this is the dysfunctional voiding. Intermittent or fluctuating urine flow caused by involuntary contraction of the urethral sphincter or levator during voiding in people without neurological condition. DSD or detrusor sphincter dyssynergia, involuntary contraction of the urethral sphincter during detrusor contraction in patients with neurological condition. DSD causes bladder outlet obstruction. Pseudo-DSD, voluntary contraction of the urethral sphincter during detrusor contraction, in patients without a neurological condition. So the DSD causes bladder outlet obstruction. So the DSD can occur when the patient actively attempts to inhibit voiding during bladder contraction. Abdominal pressure. Pressure arising from abdominal cavity, I mean from outside the bladder. This pressure is transmitted to the bladder and contributes to total intravesical pressure. The Truser pressure. Pressure arising from the bladder wall, which consists of active contraction and passive compliance force. The Truser pressure, intravesical pressure, equal intravesical pressure minus abdominal pressure. So the Truser pressure equal intravesical minus abdominal pressure. Intravesical pressure, the pressure within bladder, which consists of pressure rising from the bladder wall, that the Truser pressure, and pressure transmitted from the outside the bladder abdominal pressure. So intravesical pressure consists of two variants. That the Truser pressure and abdominal pressure. Okay, so the Truser pressure itself equal intravesical pressure and abdominal pressure. So that's by this equation. If we would like to know the intravesical pressure equal the Truser pressure plus abdominal pressure. Okay, so this is very important point to differentiate between the Truser pressure, abdominal pressure, intravesical pressure. Truser pressure equal intravesical minus abdominal. Intravesical equal both abdominal plus the Truser pressure. Daytime frequency. Voiding too often during working hours. Nocturia. Interruption of sleep one or more time because of need to void. Urgency. Sudden compelling desire to pass urine, which is difficult to defer. So sudden compelling desire to pass urine, which is difficult to defer. Hesitancy. Delay in initiating urination. The hesitancy is defined as delay in initiating urination. Onset of urination occurs well after the patient is ready to void. So hesitancy, we have delay in initiation. Intermittency, urine flow that stop and start during voiding. Test to assess voiding. Useful way to assess voiding function. Voiding diary for 3 to 7 days. Record the time and date of the following data. Each void, that's the void volume and symptom. Urgency, pain, burning. Fluid consumed, amount and type of fluid, coffee, tea, water, soda. Urinary incontinence. Symptoms, urgency, pain, burning, and activity when the incontinence. Okay. Bad and diaper number used and degree of wetness. Soaked moist like this. Recording stools, constipation, and stool incontinence might helpful. Symptom score, residual urine, urine flow rate or uroflowmetry, urodynamic study, image, retrograde, ureterogram, voiding, cystogram, and cystoscopy.